One's hard and rigid, and the other one's soft and flexible.
Okay, so the soft suction is kind of like a coiled tube, and it has a flute at the end of it. And then the hard suction or the yonk is a stiff, not flexible, hard calf that goes in. It's designed to pull thicker stuff out of the airway, chunks out of the airway, bigger pieces of stuff. The soft suction is designed to be used in the nose or if it has to go further down the back of the throat. The other thing I don't want to do with suction is I don't want to go all the way to the back where I stimulate a gag reflex. So if I stimulate a gag reflex, that also means I've stimulated the vagus nerve, and the vagus nerve can slow down a heart rate and cause bradycardia. I also can create more vomit by stimulating the gag reflex. So again, when I'm measuring, I'm literally measuring from the tip of the mouth to the back of the jaw so that I can just go that deep when I'm doing the suctioning. We have rules for suctioning. So with adults, it's 15 seconds. Children, 10 seconds, and infants, 5 seconds. So 5, 10, 15. When I'm suctioning, what am I pulling out?
Fluid in the airway.
Puke or solid.
Fluid, vomit, mucus. So if that's all I'm pulling out, why does it matter how long I'm in there?
Because if you're sucking the air,
That's what their oxygen.
you're sucking the air from them.
Okay, you're also taking oxygen. So the time limit is because there's a certain point where you could actually make your patient hypoxic by doing too much suctioning. So it's 5, 10, 15 is your time limits. If you have if you have suction that is the power suction, you want it to have at least 300 pounds of pressure. So 300 would be the minimum that we want to be able to actually create when we're suctioning for it to be effective. Always inspect your equipment. And suctioning can result in hypoxia. So make sure you watch your 15 seconds, give your patient some oxygen, suction again if you have to, but you should have that rotation. Airway obstructions. We have foreign body airway obstructions, and then you have swelling that's not foreign body airway obstructions. So airway obstructions, we have mild and we have severe. What is the difference and what do I do? So if I have a mild airway obstruction, I still have coughing, I still have voice, I'm just struggling. I'm actively choking, but I'm still moving air, I wouldn't have voice. I'm coughing, I'm still moving air. Do not intervene. If you intervene with somebody who is a mild obstruction, you could actually turn them into a severe obstruction. So you don't go up and do Heimlich on those guys. You don't go up and pat them on the back. You just coach them into continuing to cough or do what they're doing. We don't get involved unless a patient has a severe airway obstruction. And a severe airway obstruction just means that that patient is not moving air. Their lips are turning blue. They may be doing the sign where they're holding their hands across their throat because they can't actually say that they're choking. That's when we get involved. Weak coughs, the hands across the neck, no voice, blue cyanotic. That is the only time we get involved. So adults usually choke during meals. Children, it's playing. Whatever they can stick in their mouth, they shouldn't stick in their mouth. They're going to do it. Dental appliances, as far as crowns, dentures, if they are fitting good, we don't pull them out. If we're trying to bag a patient and they have good fitted dentures, that actually is a benefit for us. But if their dentures are not secure and they're just moving around in their mouth, you need to pull them out of their mouth or they become an airway obstruction themselves. They can force the tongue back. Question: gurgling sounds should trigger the need for what? Gurgling sounds should trigger the need for what? Suction. After my airway, now I go into breathing. So ABCs. I'm going into breathing. What am I looking for in a patient that's breathing? I'm looking for adequate versus inadequate breathing. So when you walk in a room And do you go in there and say, Coy sure is breathing awesome today? No, you don't notice none of that. You don't see shit with that. If you walk in a room and somebody's breathing gets your attention, that's inadequate breathing. Something's wrong if they walk in and their breathing gets your attention. That should be your first clue. There's absolutely something wrong with that. Hold on, somebody sent me a message. Okay. So consider providing positive pressure ventilation. So I'm going to bag a patient if their Qs or ventilations are greater than 28 or less than 8. Those are just specific numbers because National Registry has to put a number on there for you to get it on, for them to know you understand the concept. Now, those of us that are in the field recognize that's not always right. Some people do not breathe that fast or that slow. It's not that big a deal. But put those numbers in your brain, implant them in your brain. Greater than 28 is positive pressure ventilations. Less than 8 is positive pressure ventilations. If they're too shallow, how do I know a patient's breathing shallow?
Their chest isn't rising and falling.
Okay, chest rise and fall. If I see poor chest rise and fall, that means poor tidal volume. If I say shallow respiration, that's poor tidal volume. If I say poor tidal volume, that's poor tidal volume. And what is the only thing I have to fix poor tidal volume?
Oxygen.
Oxygen fixes perfusion. So oxygen only fixes oxygen.
BVM. The BVM.
BVM. So I can put oxygen on a patient, but if they're not ventilating, they're not going to bring that oxygen in and out very well. So remember that your BVM and your mouth to mask is all you have to fix tidal volume. Oxygen does not fix tidal volume. You're looking for retractions, tripod position, accessory muscle, sniffing, nasal flaring. Nasal flaring you're really going to see in your babies. The 1 to 2 word dyspnea, labored breathing, anything orthopnea. What does orthopnea mean? Orthopnea is how we position ourselves so we can breathe. We can't breathe laying down, so we stay sitting up all the time. A tripod position. What happens when a patient's in a tripod position? Hands are on their knees, nose is up in the air, and they're leaning forward. So what is the purpose of a tripod position?
Open the airway.
Okay, so they had their nose up to open this airway and keep this nice and straight so there's no friction loss here. Why are we leaning forward? They're leaning forward so gravity will help pull their chest down so they're not having to work so hard. By the time they get in a tripod position, they're tired. And their hands on their knees are also maintaining that position. So they don't even really realize why they're doing it. But when a person is in respiratory distress, that's exactly what they're doing. So respiratory, you have dyspnea, respiratory distress, respiratory failure, and respiratory arrest. This is kind of like saying you have compensated and uncompensated shock. So with respiratory distress, I have a patient that's struggling to breathe, but they're still barely maintaining an SpO2. It's like compensated shock. Respiratory failure, they are trying hard to breathe. They're giving it hell making an effort, but their SpO2 is in the 80s. And respiratory failure is going to turn into respiratory arrest where they're not breathing at all. Respiratory failure, they're no longer compensating. Okay. Respiratory distress patients, I can put oxygen on them and they tend to do okay. Respiratory failure patients, you're going to have to bag them. There is no such thing as just putting oxygen on a respiratory failure patient. So the physiology, so we have to have a working heart, we have to have working lungs in order for respiration to take place. So do you remember what's the difference between ventilation, oxygenation, and respiration? Yep, I'm not going to let you cheat. Hold on. All right. So what is the difference between ventilation and oxygenation?
Ventilation is air moving, and oxygenation is, the gas exchange.
So there's oxygenation and respiration are both gas exchange. What's the difference between the two? We have oxygenation and then you have respiration. Tell me the difference between those two. You're headed in the right direction, but now tell me what the difference is between oxygenation and respiration. One only deals with one thing, the other one deals with two.
Moving the CO2 out.
So oxygenation strictly deals with oxygen. It's a matter of getting oxygen to every cell in the body, getting oxygen to the brain, getting oxygen to the toes, getting oxygen to the kidneys. That's oxygenation. Respiration is getting oxygen in and CO2 out. So respiration involves both chemicals. Oxygenation is strictly talking about oxygen. It's the only difference between the two. Is everybody good with those? The difference between those three terms. So what do I have in my toolbox? So you carry this airway bag around. It's a respiratory toolbox. So we've given you suction. We've given you OPAs and MPAs. We've given you positions. Those are all in your toolbox so far. Adequate versus inadequate breathing. So we've already decided that adequate breathing is fairly quiet. You don't see a whole lot. I wouldn't call it silent, but it's quiet. 12 to 20 breaths a minute. There's not very much effort involved in it. It just happens spontaneously. You should have good chest rise and fall, equal on both sides. So I shouldn't have one side going up and the other side staying down. So abnormal breathing, less than 12. If 12 to 20 is my normal, anything less than that or over that is abnormal. Irregular rhythm. So nobody should be breathing fast, slow, slow, fast. So, right? That's not, so irregular breathing is not okay. There's only one person that does irregular breathing that is completely normal, and that is a newborn. And that's because their brainstem hasn't developed enough for them to have a normal respiratory pattern. So if you ever hold a newborn up to your face or your neck and you listen to them breathe or you feel them breathe on your neck, it's a very sporadic breathing. They don't have a regular breathing pattern, but that's normal for them because their brain is still immature and it hasn't matured enough to get that regular pattern down yet. But they're the only ones that are allowed to have an irregular breathing pattern. So increased effort, shallow depth, low tidal volume, pale blue, cool, moist skin is all a sign of poor respiration. So to my toolbox, I have the OPA, the MPA, and the positions. Now I'm going to add oxygen. Oxygen bottles, we need to be careful with them. Make sure they're secured in the vehicles. Check the stamps and dates on the bottles. Make sure they're tested and everything's up to par on there. And then you have the PIN index system and the pressure regulators and the flow meters. So the PIN index system is specific to the oxygen bottle, so it won't fit on a nitrogen, it won't fit on a carbon dioxide, it won't fit, it's got its own PIN index system specific to that oxygen bottle. Then you have your pressure regulator. It's going to reduce the pressure coming out of it, because if you felt the pressure coming out of that bottle, you don't want that going up someone's nose. So you have the pressure regulator to drop that down. Make sure you're always checking your O-rings to make sure it still has the O-ring. And then you have your SpO2, which the goal for SpO2, guys, is above 94%. So 95 to 99 is my SpO2 goal. Why am I not interested in 100?
The machine might be faulty. It might not show you 100. Or you might over-oxygenate them.
Over oxygenate. So 100 is not a number. 100 is just as high as it'll go. So there is such thing as oxygen toxicity. Comes in, it's really important when you're talking about cardiac heart attack patients and stroke patients. If they're above 94%, we're not putting oxygen on them. We don't put oxygen on people unless they're below 94%. Our goal is to get them 95 to 99%. With that toolbox, these are all the different tools that I use with oxygen that only have to do with oxygenation. And you have all of those in your bag, so, except for the tracheostomy max. So you have a non-rebreather, if you'll grab your non-rebreathers and your nasal cannula. The thing that really blows my mind about the nasal cannulas, and those of you on fire departments will probably be fine, but if you're not on a fire department, you need to practice putting nasal cannulas on people, because I cannot even count how many students I get for clinicals that cannot put nasal cannulas on patients. They're way more complicated than you think they are. So you need to kind of mess with them at home or mess with them with mannequins. So the non-rebreather, when you open up your non-rebreather, you're going to see it has a bag with it. So you have a mask, unwrap it, open that bag, pull that bag out for your non-rebreather. I can't see some of you, so I don't know if you've got it out or not. So when you pull the non-rebreather out, those of you that are not on departments are going to appreciate having to put your hands on this. So if you are on a department, I get it. You already know how to use a non-rebreather. Those of you that are not, you want to pull it out. So when you you open that mask, you pull that bag out. If you look inside that mask, you'll see at the top of that bag, inside that mask, there's a little valve. And it's got like a soft thing on it that you can kind of move. And so when you hook this mask up to the oxygen bottle, you're going to take your finger, you're going to put it on that valve, and you're going to keep that valve closed while you fill that bag up like a balloon. And that's what you'll fill up before you put it on your patient's face. Does that make sense? So the purpose for that is so when they're inhaling, they're not collapsing that bag. So you want to fill that bag up with air before you put it on their face. Then it has the metal clasp that goes over the nose. That's just going to help you fit it around their nose. And then you have the straps that go around their head. Okay. So when you get to skills, he's going to have you hook these up, that where you put your finger over that valve to make sure you inflate that bag before you put it on your patient. And then just fit it around them. And that's high flow oxygen. So those are set on 10 to 15 liters. The lowest you can set your flow meter at is 10, and the highest you set it's 15 with a non-rebreather on. Now, if you take the nasal cannula, that's also called high flow oxygen. If you take the nasal cannula out, it's the one that has the two little prongs that go up the nose. So the nasal cannula is designed for the two prongs to go in their nose, and then you take it and wrap it around the top of their ear, and you come under their neck. So in the nose, around to the top of the ears, and then underneath their neck, and then you'll pull that tight. Trust me, you might not want to, if you don't want to do it now, I get it, that's fine, but practice it in the mirror or go try to put it on yourself after class or during break, because we take for granted a lot of times when we're teaching that this is simple to put on, but I can tell you from the many students that have come through our station, we do not do a good job of teaching people how to put nasal cannulas on, because it's one thing to watch somebody do it. It looks really simple, and then give them a patient when they've never put it on one. It's not that simple. So do me a favor and mess with your nasal cannulas. Those are low flow oxygen. So if my goal is 94 and my patient's at 92, the 2 to 6 liters a minute is what I flow a nasal cannula at. Low flow would be like my 92 patient that I'm wanting to get to 94. High flow is going to be somebody 90 and below. I'm going to put them on 10 to 15 liters. Low flow is 2 to 6 liters nasal cannula. The tracheostomy mask, so if somebody has a trach, they have a little mask. It looks like an infant mask that can go directly over their trachea. Remember, when you're talking about tracheas or people who have a tracheostomy, we don't have to do a head tilt chin lift. We're not doing any of this positioning because they already have a direct path into their trachea. So now we added oxygen, nasal cannulas, non-rebreathers, and tracheostomy masks to your toolbox. Now let's add a BVM and a mouth-to-mouth mask. You have both of those in your bag. So BVM has the hard bag with the mask on the top of it. And if you pull that out, if you take that mask off, you'll see a little tube that mask plugged into. That little tube will fit on somebody's tracheostomy collar. So if they have a trach, you can take the mask off and hook it directly to their trach. And that is how you could bag that patient. But just realize that you would have to cover their nose and mouth, or otherwise when you go to bag them, it's going to take the path of least resistance and it's going to come out their nose and their mouth. It's not going to go down into their lungs if they're breathing through a hole in their neck. Now, the things you have to know about a BVM is a BVM does not provide oxygen unless you hook it up to oxygen. A BVM only ventilates, it moves air. So I have to, in turn, hook it up to oxygen. I need to have the air positioned. Otherwise, when I'm bagging this patient, I'll be putting air in their stomach, which is going to eventually come out as vomit. None of us likes that. The mouth-to-mask is the most efficient way for a single rescuer to provide ventilations versus the BVM. So the BVM requires me to do a C-clamp, and when you get into skills and you mess with these mannequins, you'll see the difference. It's hard for one person to maintain a seal with the mask and squeeze the bag. And just because the bag is this big, does that mean I have to squeeze the whole bag to give that patient air? No. As soon as I see chest rise, I stop squeezing that bag. Because if I keep squeezing it, where's that air going?
Stomach.
In the stomach. So they're going to get gastric distension, which now you're going to put pressure in that stomach. You're going to blow that stomach up, which is going to put pressure in my chest cavity. So not only do I have pressure everywhere, but I also have a patient that's getting ready to vomit, that is unconscious and is now going to aspirate that vomit. So if I had a choice between mouth-to-mask or single-person BVM, mouth-to-mask is the most efficient because it's easier to maintain a seal. If I have two-person BVM, then BVM is the most efficient. But that's because I have one person whose whole responsibility is to maintain a seal, and the other person's whole responsibility is to squeeze the bag. Question, during primary, what comes first? Primary assessment, what comes first? Exactly, positioning. So remember, with our airway and our opening our airway, it's position, maintain, and suction. So position our patient is number one. An OPA and an MPA is only good for maintaining a hole if I already established it. I had to establish it with the positioning in order to do an OPA or NPA. And a nasal cannula has nothing to do with an airway. It's strictly breathing. So the other two would automatically come before the nasal cannula because the nasal cannula is part of my B, and we're working at A comes before B in our primary. CPAP is the other thing you're going to see. So continuous positive pressure airway. So continuous positive airway pressure that okay, let me finish this slide and then you can go because then breathing's he's gonna chunk it at me. I knew it. Okay, so do your CPAP first, and it's continuous positive pressure airway. So there's continuous pressure. Even when I'm exhaling it, it's going against pressure. This is to force air through those alveoli. If they have fluid in their lungs, it forces the fluid back into where it belongs and gets it out of the lungs. CPAP is also known. People will wear it if they snore a lot at sleep because it keeps their airway open. But this patient has contraindications. I cannot use it on a patient with low blood pressure. I cannot use it on a patient with altered mental status. And I cannot use it on a patient that's not breathing. So it will only work if the patient can stimulate their own breath. It's going to drop their blood pressure because I'm putting pressure inside their chest. Remember, in the word, continuous positive pressure in the airway. So if they have low blood pressure already and I put CPAP on them, I'm going to make them go unconscious because I'm going to drop their blood pressure. So they have to have 100 systolic minimum to qualify for CPAP. It moves air, it moves fluid out of the lungs, and it helps them to respirate. Everybody, take 5.
Arnie,
Yes.
no, when I talked to you on the phone today about the exam,
Uh-huh.
what exam did you say?
So pericardial tamponade or tension pneumo. So with pericardial tamponade, there's infection or blood in the sac, and with what they need is they need that sac open. It's called a pericardial centesis, and that has to be drawn out. So it's rapid transport. But when all that fluid is in the sac that surrounds the heart, it starts to crush the heart to where the heart can't pump right. The other common one you're going to see is a tension pneumo, and that is when they have a punctured lung and they have fluid or air that builds up in the chest, and they need a needle decompression to let the air out of their chest so that their lung can reinflate. Then you have distributive shock. Now, distributive shock, think of the word distributive, so it's distributed throughout the body. What do I have that's distributed throughout the body? Not a heart, not lungs, not an obstruction, but my actual veins, my vessels. So with distributive shock, I have a complete relaxation of my blood vessels. So I take this container that was as big around as my pinky, and I now make it as big around as my thumb. That's like taking a full glass of water, and I take this same amount of water and I pour it in a container this wide, and it looks like it's half a glass of water, correct? So when my blood vessels vasodilate, it looks as if I've lost half of my blood that was in my body because I lost the structure to my blood vessels. Now there's 4 to 5 types of distributive shock that all relate to this type of problem. And that is sepsis, neurogenic, anaphylaxis, and psychogenic. Again, you need to find the one thing that makes this stand out from all the other ones. So distributive shock is vasodilatory. My blood vessels in my entire body relax, giving the impression that I just lost a lot of blood. Sepsis, the key to recognizing septic shock is going to be fever, illness. So sepsis, think of a septic tank. This is a patient who has an infection that's gotten so bad now, it's put them into shock. It's called septic shock. How am I going to know my patient is septic shock, not hypovolemic shock? How am I going to know my patient is septic shock and not cardiogenic shock?
They're
Fever.
going to be ill.
Fever. Have to have a fever. A patient that's in shock with fever is septic shock. We're not trying to memorize blood pressure. We're not trying to memorize tachycardia. We're not trying to memorize all that other crap. They got a fever and they're showing me signs of shock. That's septic shock. They need antibiotics, rapid transport. Neurogenic shock. So the nervous system. So with the neurogenic shock, The only thing that makes this one very unique is one, it's typically going to have to do with a tumor in the spinal cord or some type of trauma to the spinal cord where we removed a fuse out of the fuse box. So the nervous system is a huge fuse box. We now blew a fuse in one area. So what happens to that area of the body?
Doesn't work.
Doesn't work. Everything's completely flaccid. So all the blood vessels in that area of the body completely relax and vasodilate, drops my blood pressure. The only thing that's different with this, guys, is these guys can have a low heart rate because it's affected by their nervous system, and the nervous system controls my heart rate. So if I get a injury to the nervous system, there is a chance that my body's not going to get the message to increase that heart rate. Well, the other thing is they're warm and red below the injury and pale and cool above the injury. Why are they warm and red below the injury and pale and cool above the injury? So if everything below the injury completely vasodilates and relaxes, where does all my blood go?
To that area.
To that area. So that area is going to be full of blood. It's going to be warm. It's going to be red. So my body compensates for shock by vasoconstricting. So it constricts my blood vessels and increases my heart rate. So if I take all my blood vessels above the injury and I constrict them, what color is my skin going to be?
Pale.
Pale. I'm taking the blood away from it, putting it into the core. So with these guys, it's still positioned, but it's probably going to require spinal immobilization because most of the time this is a traumatic patient. Blanket, high flow oxygen. Anaphylactic shock. How am I going to know a patient is anaphylactic shock? So when they get stung by something or they have an allergic reaction, their body recognizes it, it freaks out, it overreacts, and it does a vasodilation throughout the entire body. So all my blood vessels relax. This causes swelling. It causes difficulty breathing because I start to have vasoconstriction inside my lungs. So my blood vessels or my bronchioles inside my lungs constrict up because whatever freaked out my body, my lungs are afraid of it too, so it's trying to keep it out. The only fix for this is epinephrine. They need their EpiPen. This is the only time you're going to see a medication administered besides oxygen in the primary survey. So epinephrine for adults is 3, and for pediatrics, it's 1.5 milligrams. And there is such a thing as people, one, not knowing they're anaphylactic. Whitesboro, you got my daddy out there now, and he is an anaphylactic bad. So if he gets stung by a bee, a fire ant, a wasp, anything that stings, he has anaphylaxis to the point that probably from the time you get to your fire station to the time you get to his house, he will practically be unconscious if mom hasn't poured a bottle of Benadryl down his throat. So, and he doesn't have his EpiPen. So he is one of those that drops really fast. In less than a minute, he will go from walking to crawling to stridor. Okay, so just heads up, if you get called for anaphylactic on Crow Road, just know it's going to be the real deal. And hopefully, if they called you, it means they didn't have his EpiPen. Just an FYI. If you don't carry EpiPen, shove Benadryl down his throat. Really bad anaphylactic. So some people react really fast. Some people will react over 20, 30 minutes. Some people can wait. If it's a digested thing, they're having problems. So you have the initial introduction of the antigen into the body. So everybody who's anaphylactic, they say, well, I've been stung before I didn't have this problem, so I didn't know I was anaphylactic. Well, that's because you have to have the first exposure with no reaction before you get an anaphylactic reaction. Your body doesn't know to overreact to it until it knows what it is. So you do have the initials. So that's why medications, when a family changes medications or a patient changes medications, it might take them 2 days to have an anaphylactic reaction. Because when they first took the pill, their body was fine with it. As they keep taking it, then they end up with an anaphylactic reaction. I'm looking for rashes. I'm looking for history. Recent change in medication. Ate some seafood. Had some peanuts. Went outside to the park and got stung by something. I'm looking for something in the history to give me a clue about this anaphylaxis. Psychogenic shock is distributed. Vasodilation throughout the body causes me to pass out. The thing that's unique about psychogenic is it's temporary. It's not a permanent thing. It's a temporary thing. So these are the patients at a funeral or got in a fight with a boyfriend. Someone calls 911 because they passed out. By the time you get there, they're fine. This is because whatever caused their vasodilation was from a visual or audible stimulus. And once that visual or audible stimulus was gone, so once they passed out and they no longer got that stimulus, they quit vasodilating and they came back to. Most of the time, these guys will refuse transport, but you just need to be cautious and make sure you're not missing a stroke or something that may have happened or a TIA. But psychogenic is temporary. That's the key to psychogenic. Respiratory insufficiency is exactly what it says, guys. They're not breathing. That's respiratory insufficiency. The risk for treating older patients with shock is if they're on beta blockers, they can't increase their heart rate, therefore they can't compensate. It's no different than treating anybody else. Just know you need to be pretty suspicious. So an average person, we're looking at 120, 130, 140 heart rates. But when you're talking about elderly patients, they can be in shock with a heart rate of 90. And it's because their hypertension medications don't allow them to compensate. Their hypertension medications block the tachycardia from happening. If your patient is a trauma patient or a unconscious patient, they get a rapid head to toe, which shouldn't take you more than 60 to 90 seconds to do from head to toe, looking for anything you may have missed. We're not treating fractures. We're not splitting fractures. We're strictly looking for injuries or signs of what's going on in a rapid head to toe. And the last thing about your primary is transport. Is this a load and go or a stay and play patient? Am I transporting via helicopter? Am I transporting by ground? The last part of your primary is to make that decision, load and go or stay and play. This is when the golden hour comes into play. You want to get your patients to the hospital within the hour of injury on your trauma patients. Guys, we're 20, 30 minutes into a golden hour, typically by the time we get on scene. And at Cook County, we can be 40 minutes into it with some of the rural areas that we try to go to. Load and go or stay and play. Question. This patient is at risk for what type of shock? By the way, that is a temperature and it is a fever, even if it's in Celsius. Sepsis shock. Fever is sepsis. History taking, you want to get a history for your patient. When did this start? Sample, OPQRST. Those are the mnemonics that you use to try to remember these. So sample stands for signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and events. Signs and symptoms, allergies, last oral intake, medications, history. Why would I want to ask them when was their last oral intake? Well, it's because if this patient needs surgery, it's pertinent to them on what type of medication they're going to be given to sedate them in the OR. Depends on when was the last time they put any food in their belly. And if this patient goes unconscious before you get them to the hospital, you're going to be the only one that's going to be able to answer that question. So when you get to OPQRST, it's onset, provocation, quality, radiation, severity, and time. So onset, when did this start? Provocation, is there anything that makes it better or worse? Quality, how does it feel? Sharp stabbing pain, dull pounding pain? What is the quality of the pain? Radiation, does it go anyplace else? Does it go up to my jaw? Is it in my back? Severity is the 1 to 10 scale. And then timing, how long has this been happening? Those are different kinds of questions. So when you're doing a patient assessment, you are a detective. And you're trying to figure out what's going on. Well, you can't figure out what's going on if you're not asking questions. And you have to ask the questions and get the answers. But you have to ask the right questions to get the answers you're looking for. So sample and OPQRST are something you get on everybody. And you can start getting your history as soon as you walk in and start talking to your patient. What brought us here today? What's going on? When did this start? What does it feel like? When we get into trauma and medical emergencies, you'll start understanding these different types of questions more. And the answers to those questions are going to help guide you to your diagnosis. Special challenges. If you have a patient who's not, remember when we talked about open questions and closed questions? So I ask open questions to patients who are not very talkative when I want to get more out of them. And I ask closed questions for patients who never shut up or they're having difficulty breathing so they can't do long answers. Then I'm going to ask closed questions. What about interpreting? What about if there's a language barrier? How would I get a history from someone if there's a language barrier? Oh, I'm back. Okay. So, don't even. I saw that shit. Assholes. Okay. I've been doing this since 8 o'clock this morning. I'm over it too. Trust me. Y'all are so lucky I'm not in a classroom with you. You have no idea how blessed you are. Okay. So, yeah, 'cause you get to talk and run your mouth, and I can't hear a damn word you're saying. All I can see is them lips moving. Uh-huh. Okay. So, what do I do with language barriers? What are some ways I can address language barriers? So get an interpreter or somebody who can help you. Now, what should you take into consideration? Because majority of the time, it's their children that are interpreting for us. What are things I need to take into consideration if a child is interpreting for a parent?
Need to understand.
Their knowledge.
Their knowledge. What about whether or not the parent's going to be honest? So if you ask grandma if she's hurting and she's having to use her granddaughter to interpret, how honest do you think she's going to be to her granddaughter?
Not very.
Probably not.
She's not going to want to scare her. She's not going to want to upset her. So what's coming out of her mouth might not be truth, and you really need to be paying attention to body language. Okay? Is she really hurting, but she's trying to protect the granddaughter so the granddaughter doesn't get scared? So remember, when you start dealing with language barriers and children as interpreters, that can get a little sketchy sometimes. So we have scene size up, primary, and then we go into secondary. Secondary is when I get my vital signs. Secondary is when I do, if I have a medical patient, I'm assessing body systems. So cardiac, digestive, respiratory, neurologic. If I have a trauma patient, I'm assessing body parts. Head, eyes, ears, nose, mouth. Toes, fingers, belly, everything, right? So body parts for trauma patients, body systems for medical patients. Listening to breath sounds, palpating the abdomen, look, listen, feel. So think about your cardiac assessment. Your cardiac assessment requires look, listen, feel. I look at the EKG to see if I have electricity. I feel for a radial pulse to check how strong the muscle is, and I listen to heart sounds to see if their valves are working. So if I don't do look, listen, feel, I'm going to miss out on one of the assessments of that body system. So always think of look, listen, feel when you're assessing. I can see a deformity. I can see swelling, but I can't see a fracture. I can palpate crepitus. Look, listen, feel. Rebound tenderness. What is rebound tenderness in the abdomen? So rebound tenderness is when I push on the abdomen and I let go. And when I let go, that's when they have the pain. So if I'm not touching this patient, I can't assess for rebound tenderness. But that's one of my clues that I have appendicitis instead of gallstones. So there's rebound tenderness in appendicitis. Your focused assessment, the only time you can justify doing strictly a focused assessment, okay, if my patient is complaining of chest pain, then I can do a focused assessment in cardiac and respiratory. I don't have to ask them about their bowel movements. Right? So I can do focused assessments in those areas. If my patient's unconscious, I can't do a focused assessment. I have to do full body. My respiratory system, what am I looking for, guys? This is all you. What am I looking for on these different body systems? If I'm assessing a cardiac system, what am I looking for?
Can you repeat the question?
If you're assessing, I'm going to change it to cardiac because I don't want you reading my slide to me. So if you're assessing a cardiac system, what are you looking for? What are you assessing?
Also,
You're looking for the EKG reading, the pulse, and look, listen, and
Live. You're not a paramedic.
But you're looking at pulse, rhythm, regular depth.
Regular, irregular, pale, cool, clammy skin, right? It's all cardiac. So if I'm assessing the digestive system, what am I looking for? Digestion.
I think you're going through a tunnel, are you?
Digestion. If I'm looking through checking a digestive system, what am I looking for?
Distension.
What are some questions I'm going to ask this patient?
When's the last time you ate or drank anything?
Last bowel movement or the.
Last time you took it down.
Exactly. Think of what is your digestion system supposed to do? Are they normal? Is there blood in there? Have you been able to pee without pain? Have you had diarrhea? Have you vomited? When's the last time you ate anything? Focus on your system that you're assessing. Respiratory, I'm going to listen to breath sounds. How fast are they breathing? Do they have good tidal volume? Do I have good chest rise and fall? Cardiovascular, pulse, quality, rhythm, and pressure. Do I have a good radial pulse? Is it together? Is it weak? Is it thready? Is it bounding? Question. What question represents onset of OPQRST? How would I ask this patient about onset? When did this start? Yes. So rate your pain on a scale of 1 to 10 is the S for severity. And time, the T for time, is how long has this been going on? So the O for onset is when did it start? When did it begin? Your neurological system, look at the pupils. Are the pupils dilated? That's going to be parasympathetic. Are the pupils constricted? Having way too much fun over there, Whitesboro. Are the pupils constricted? Are they dilated? Are they have an opiate overdose? Do they have a benzo overdose? Do I have one pupil bigger than, so this is a blown pupil, the bottom one on the left. Some people, they normally have that. That's anoscoria, but they would tell you because they know it's going to get your attention. So they would tell you, I have a pupil that's messed up. If my patient has altered mental status or had syncope or numbness or tingling, any signs of the nervous system, pupils are a good thing to start looking at. The pupil is a muscle that is controlled by the nervous system, and it's the parasympathetic or sympathetic nervous system, so fight or flight or feed or breathe. So it's a good sign into the activity in the brain. What's their level of consciousness? And we'll talk about GCS later. Neurovascular. What's the difference between neurovascular and neurological? Neurovascular, vasculature is the feelings we get. So numbness and tingling is neurovascular. Paralysis is neurovascular. When I check pulse, motor, and sensation of a patient, so motor tells me they can wiggle their fingers. Sensation says they can feel me touching them. So when you go down your spinal cord, there's sensation on one side and motor on the other. So if I get a damage to my spinal cord and it only breaks off half of my spinal cord, I could still have motor, but no sensation. Or I could still have sensation, but no motor. So when you ask somebody to move their finger, and they move their finger and you say, yep, pulse motor sensation's good, that's not accurate. You just assessed that motor was good. That doesn't mean that they can feel you touch them. It's two different things. And then secondary is also when you would get vital signs. Blood pressure, respiratory rate, pulse rate, and when you have your next clinical or your next skills day, that's when they're going to be working on vital signs and getting your vital signs. Pulse oximetry, blood sugar. All of the following are types of distributive shock except. Remember, there were 4 types of distributive shock. Which one was not a distributive shock? Distributive shock is a container issue. Yikes. So hypovolemic was one of the first shocks we talked about. It is all shock is hypovolemic till proven otherwise, and hypovolemic has to do with volume or fluid. Distributive is container. Distributive is the blood vessels only, and they just vasodilate throughout the whole body. And that happens in neurogenic, sepsis, and anaphylaxis. So you have hypovolemic, you have cardiogenic, and distributive. Anaphylaxis, sepsis, and neurogenic all fall under the distributive title. Make sure you watch the shock lecture. And reassessment every 5 minutes for unstable, 15 minutes for stable. And what am I trying to do during reassessment?
If you missed anything,
Did we miss anything? Is what we're doing working? Do we need to change our plan? 15 minutes for stable patients, 5 minutes for unstable patients. Reassessment is all the way back to ABCs and forward again. You always go back to ABCs and make sure nothing changed in your ABCs. So reassessment includes your primary. Question. To establish the L in sample, what question are you going to ask? Good job. Last time you ate or drank anything. During patient assessment, what comes first? So y'all got trigger happy with that airway because we've been talking ABCs, 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 but what always comes first? Scene safety. All right. Last bit is pharmacology, and it's just you have 5 drugs that you have to know, and you have some terminology. So the terminology you need to be familiar with is going to be pharmacology is the study of drugs. So ology is always study of. Pharm is the root word for pharmacology is medications. Medications is the substances used to treat or prevent disease. Pharmacodynamics. Dynamics is how does the medication work in our body. And it's either an agonist or an antagonist. An agonist is going to promote something to happen. An antagonist is going to block something from happening. So an agonist is going to encourage it. Antagonist is going to stop it from happening. You have doses for age, weight. The action describes what does this drug do inside my body. Indication, why would I use it? Contraindication, when could I not use it because it would be hurt the patient. Put that white flag down. You had at least 10 more minutes. And then contraindication, when would I not use it? And side effects, these are, these happen, but they're not going to kill the patient. So the side effect is worth dealing with. Okay, so we have about 7 slides left and 4 questions. Do you want to break or do you want to push through them? Some are saying break, some are saying push through it.
Keep going.
Okay. Names, the main thing you need to know about names is that generic names are lowercase, trade names are uppercase. It's the difference between acetaminophen and Tylenol. Both the same drug. Generic is lowercase. Your trade name is uppercase. Ibuprofen and Motrin. You want to know that you have prescription drugs, over-the-counter drugs, vitamins, recreational drugs. Those are all considered drugs. And anytime you administer drugs to a patient, you always have to ask the 6 rights. Right dose, right route, right time, right person, right med, and is it expired? So know your 6 rights before you administer a medication. Right dose, right route, right time, right person, right med, right date. The forms it comes in, you have tablets versus capsules, solutions versus suspensions, metered dose inhalers, topicals, and then gases. So tablets and capsules. Capsules I can break apart and they have medication in them. Capsules is one solid pill. A solution versus a suspension. A solution doesn't have to be shaken up. A suspension, think of the word suspended. There's particles suspended in it, and I have to shake it up before I administer it to a patient. Gels, metered dose inhalers give the same exact dose every time you push it, and gels are given orally. Transcutaneous is on the skin, so that's going to be any type of lotions or transdermal patches that patients have. Nicotine patches, fentanyl patches, those are all transdermal patches. What are your jobs for administering medications? You have peer assisted, patient assisted, and EMT assisted. So peer assisted is giving your partner a Tylenol. Patient assisted is when you help them administer a drug that's their own medication that's prescribed to them. You're just assisting them with their own medications. An EMT administered is when it comes off your truck and gets given to that patient, but they're not prescribed it. That's the differences. And Med Control tells you how you're allowed to give your medications. So here is the medications you have to know inside and out, and there's 6 of them. Activated charcoal. I give it for overdoses of less than an hour. It goes into the stomach and it absorbs all that poison that's in there, and then it makes them shit a brick. So a side effect is constipation. It absorbs so the body can't absorb it, but it has to be given within an hour, so it's oral. Well, obviously, if they've got to eat it, then they can't be unconscious and they can't be at a risk for aspiration. The dose is 1 milligram per kilogram. Oral glucose. Oral glucose is given to diabetics. It's 15 grams in 1 tube. It's given for an altered mental status. They can be confused. I give it orally. I can put it in the cheeks if they're more confused than normal because I don't want to squeeze it down the center of their mouth. They can't be unconscious. They have to be able to protect their own airway. Aspirin. All patients who have chest pain get aspirin, 325 milligrams if it's an adult aspirin, 324 if it's for baby aspirin, because they only come in 81 milligrams. You want to get it on this chest pain patient as soon as possible, as long as they have had no aspirin within the last 12 hours. So if you ask them if they've taken an aspirin today and they say, yes, they've had 1 baby aspirin, how many aspirin should you administer to them?
3 more.
3 more. So they get a total of 4. Okay. When do they get it? This is for chest pain patients. What does it do? It prevents platelet aggregation. So it takes these platelets, it smooths them and buffs them out so that this sticky platelet is not going to stick onto this clot as it goes by it. It doesn't break down clots. So when people say, well, they can't take aspirin, they're on blood thinners, that is false. Okay. This just is a platelet. Most blood thinners have to do with fibrin, not platelets. Nitro, sublingual nitro goes underneath the tongue. It's very strong. It's a vasodilator in the coronary arteries. So it takes this coronary artery and it opens it up. So if they have a clot in their coronary artery that's causing this heart attack that is blocking any blood from getting to that heart, the idea is if you give them nitro, it vasodilates that, so now blood can hopefully get around that clot instead of just being stuck at the clot. You're going to open that blood vessel up a little bit more. Because you're opening blood vessels up, you're also opening them in the head, so one of the side effects is headaches. This patient has to have a blood pressure over 100 systolic in order for you to give it because it's going to drop their blood pressure. You can give it, you can repeat it 3 times. The patient has to be prescribed it. I don't give nitro that's not prescribed. And you have to take a blood pressure every time you administer it. So if you give 3 doses, you have 3 blood pressures. Because if their blood pressure drops, you can't give this to them. If they're having a heart attack and you give them nitro and it opens it up, you could perfuse that heart. But if they're having a heart attack and you give them nitro and you drop their blood pressure to nothing, you're going to put them in cardiac arrest. So really know your rules about nitro. if they've had any Viagra, Cialis, or Levitra within the last 24 hours, which it blows my mind how many do, then you cannot give them nitro because that is a vasodilator. They're already going to have a lower blood pressure. And when you give them nitro, it compounds that effect. So you have to ask them before you administer it. EpiPen, 3 milligrams for adults, 1.5 for kids. Directly in the thigh, hold it for 10 seconds so that it can administer the medication. It's giving during anaphylaxis. It's one of the only medications you will give during your primary ABCs. All other medications are not given until after secondary assessment and vital signs have been taken. Narcan is given intranasally. It's given for opiate overdoses and patients that are not breathing. It blocks the opiates so that now the patient's opiates cannot create an effect and your patient can start breathing again. Just know this patient's at risk for seizures, vomiting, and beating the shit out of you if you give them too much Narcan. Okay, so you just took their high. The other thing to be cautious for is your home hospice patients that are on high-dose morphines for pain management. If they got overdosed on morphine, you could give them just a half a dose of Narcan to bring them back to breathing, but don't give them a whole dose of Narcan. You don't want to take all their pain medication away. There's a reason they're on high-dose morphine. So the last thing we would want to do is throw this hospice patient into DTs. And then you have oxygen, which is an inhalation drug. Difficulty breathing or hypoxia, that's when we're going to give it. You have nasal cannulas, non-rebreathers. Nasal cannula 2 to 6, non-rebreather 10 to 15 is your dosages. Albuterol is administered for a bronchodilator, so it takes those bronchioles in the lungs that are constricted up and they're tight, and that's why your patient is wheezing when they exhale, so it creates that whistle. And it bronchodilates them and opens them up so more air can get in and out. It's like relaxing a muscle that's constricted. That's what albuterol does. But one of the side effects of albuterol is it increases the heart rate. It creates nervousness and tremors. So if your patient starts having nervousness and tremors after a breathing treatment, that's 100% normal side effect. Okay? But it's designed to relax those bronchioles that have constricted up and they're having a hard time breathing. Question, what is the flow rate for this piece of equipment, a nasal cannula? What do you flow that at? Okay, 2 to 6. Notice I did that again where I put that 2 in there because a lot of you are going to see the 2, recognize the 2, and jump on it. Okay, 2 to 6. Anything above 6 in a nasal cannula is going to make their nostrils flap around and sound like they're clapping. Okay, that's going to be too high going up in their nostrils, anything above a 6. They're not going to be happy with you. CPAP is contraindicated in which patients? A blue patient, an altered mental status patient, or no altered mental status patient, or a low blood pressure patient. Low blood pressure. So CPAP will drop their blood pressure. So if they already have low blood pressure, I cannot put CPAP on them. Okay, CPAP is going to drop their blood pressure already. So think about CPAP goes on your respiratory distress. They typically have high blood pressure already. So they do benefit from CPAP. But if they have low blood pressure, you're going to kill them by putting CPAP on them. Which drug should you consider for this patient? Bunch of pills. Looks like it might be an overdose. I don't know. Activated charcoal. Nitros for chest pain only. Which drug should you consider for this patient? Chest pain. Aspirin. Which drug should you consider for this patient? A bunch of bees. Ha. Y'all got that one down. And which drug should you consider for this patient? Look at y'all. Ending with a bang. Last two questions, 100%. That's a good note to end on. So, what questions do you have for me? Jesus.
Video during Sunday, correct?
Huh?
Do we have a scene size up video due on Sunday?
Yes. So on Sunday, you need to have a scene size up video. Now, here's the thing. JB Learning could not tell me how long or how much it would hold on videos. So we'll see when you upload them. If you have problems with them, just email me. But basically, all you need to do is I want to see a video as a checkoff, as in you doing the 5 components of a scene size up. You can use your phone. All you do, record a video, scene, tell me what scene you set up, scene safe, mechanism or nature, how many patients, do I need resources, and see whether the patient needs C-spine or not. Just those 5 components. Only the scene size up aspect of a patient assessment. You can do it as a team. You can do it as an individual. I don't care how you do it. And you can just do it on your phone. And I think they were telling me that there is a JB Learning app you guys can do on your phone also. You might check into that. But otherwise, basically, record it on your phone and ship it in. Any questions? So if you go now, there are a lot of people not watching the recorded lectures. Don't call me and bitch and whine and cry about your test grades. Because the first thing I'm going to do is I'm going to go to your JB Learning. I'm going to look at your JB Learning. I'm going to open the videos and see how much you've watched. And I can see if you shut it off halfway through. I can see if you never opened it. I can see if you watched it all the way through. So the first thing I'm going to do is look and see, okay, what kind of effort is the student putting in? If the student is putting in 100% effort, they're going to get 150% from me. If the student is putting in a 20% effort, you're getting 20% from me, and that is already existing. More than that is existing on Wednesday nights, so that's all you're getting. So make sure before you complain to me that you are putting efforts into what you're doing, because I can't want this for you guys. You have to want it. All I can do is help you along the way.
Are you talking about the videos that you upload to YouTube?
You don't have to upload those to YouTube. I mean, you can. I think you can upload them to YouTube, and then you can put them on there. But supposedly, they have a way. They said you could literally just take it straight from your video and drop it into their Dropbox on JB Learning. But if you're one of those that's familiar with YouTube and you know how to do that, you can do that too. That's fine with me.
Where is that at?
It's in your assignments underneath that tile. If you'll scroll down on that tile, let me pull JB Learning up.
For patient assessment.
I think it's under patient assessment, yeah. JB Learning. So that's the infant choking. So it might be, because we were doing it before. So that one probably is in your medical term, human body. Well, shit. No, I don't know where it's at. Well, y'all aren't going to be able to find it if I can't find it.
Oh, I see it. It's in EMS Ops.
Oh, it was at the beginning. So let me show you what I'm talking about real quick. So if I go to lectures and I pull up this lecture, for me, I can go into analytics and I can look at engagement. And then I can actually go into the audience. I'm not going to pull that up because it'll pull names up. But I can actually go into the audience and I can pick each individual person and I can see what they're viewing, what they're not viewing, how many times they've been on JB Learning. Have they looked at any of the flashcards? Have they looked at any of the PowerPoints? You leave an imprint, you leave a footprint on JB Learning, and I can follow your footprint. And it's not a bad thing because if you're putting an honest effort in, I will do one-on-one tutoring. I don't care what it takes to get you where you need to get. If you're not getting something, I'm going to help make sure you're getting it. But if you don't have a footprint, I'm not going to be your footprint. You have to have a good footprint for me to follow. Sound like a deal?
Deal.
Just sound bitchy?
No, I just didn't have. I don't have a footprint to be honest, but I now know how to start putting a footprint in. I was very confused. I over confused myself.
Yeah, it's real simple. Click the button that says Marnie's lectures and watch them.
Awesome.
Don't make it
That'll
difficult.
help.
Yes.
Yes.
So really, guys, those are your class. Those lectures are what you would be getting inside class. So just coming to the Wednesday lectures and thinking that's going to hang it, it's probably not going to hang it. Now, you guys that have already been through the class and it got interrupted with COVID, it might hang it for a bit. But you guys that are coming in with nothing, only participating in Wednesday nights, you're not going to make it. It's not going to happen. You have to watch those videos. And I made sure that there's some that are kind of lengthy, but for the most part, they're 15, 20-minute videos. 8, 9-minute videos. I tried to keep them short. All righty.
Payments. Are we supposed to already have those in?
So what?
Or to pay for the whole course? I just never figured that out, or who I need to pay to.
Has Sadie gotten a hold of you?
I haven't talked to Sadie since your house.
Oh, well, shit. Okay. Yeah, she's supposed to be. She did start a new job though, so she might be behind on contacting people. So
okay,
she has a Venmo set up. You can mail checks. She'll meet you if you want to meet up and make payments. She does it all kinds of ways. Do you know what you want to do?
we'll probably do a check, and I can just bring it by your house on the way to skills or whatever sometime.
Oh, that's fine. And you can give it to one of the skills instructors too as well. So where do you do skills? Do you do it here in Valley View?
Gainesville.
You do it in Gainesville? So yeah, just bring it to one of the instructors.
Okay.
Okay.
Sweet.
Who is that?
That's my son.
So I hear noise, but I can't tell where it's coming from.
That's
If we
right.
have our names, do we need to send them to you?
If you have what?
Our names like 100, 200.
Yes, so you can email those directly to Sadie.